Recording in progress.
I'm sure, and I recognize your name, so I have my name too. For purples, I think.
You're good, you're good.
All right. Good afternoon. We're going to start a little earlier. I know we're supposed to start at 3:45. So welcome to our first breakout session. This is the family domestic issues session with the AAPI community, domestic and intimate partner violence and gender roles. My name is Shane Chen. I'm the moderator for this facilitator for this particular session. What I'm going to do today is actually introduce the panelists and allow the panelists some time to present their knowledge and information, followed by a group discussion, which we invite the audience in the Zoom online virtual to also take part. Please be sure to type in your questions and concerns, and that way we will read it out loud for the panelists to be able to answer. With that, we're going to go ahead and get started. The audience here, we're in a circular table environment today, so it will be very much a kind of a table conversation, table side. So feel free to ask questions and be able to kind of share some of your thoughts and your experience from the community as well. We want this to be a conversation that can also trigger some thoughts and some documented action item for us to be able to carry on post this summit. With that, what I'm going to do is start by introducing Rachna Carey with DAIA. Rachna is the executive director of DAIA, a Houston-based nonprofit whose mission is to empower South Asian survivors of domestic and sexual violence with culturally specific services and to educate the community to end the cycle of abuse. Since 2016, Rachna has spearheaded DAIA's growth, including increase in revenue from 4,400,000 to 2 million, very impressive, and clients volume from 250 to 640 survivors. Rachna serves as a founder of the South Asian Survivors and Organizations and Ally Rising, and also a board member of the Texas Association Against Sexual Assault, and on the city and state committees that advocates for community protection for underserved survivors of violence. With that, I'm going to go ahead and turn it over to Rachna.
Thank you so much. It's so nice to see everyone today and be in a nice circle with everyone. So what I'm going to be talking about is domestic violence specifically, and everything that you'll hear today is relevant to all communities, but I will be highlighting some of the challenges and barriers that that we see in the AAPI community. Oops, sorry. Go ahead. I'm gonna make sure the people on Zoom can see the screen. Yeah, sure. No rush.
Audience, are you able to see the PowerPoint? If you don't mind responding in the chat for a yes or a no.
You can give thumbs up.
Make it better is always a little better.
So while we're waiting for the PowerPoint presentation, I'm going to go ahead and actually continue presenting introducing the presenters. Following Rachna Kari is Dr. Rose Yang with Menninger and also Baylor College of Medicine. Dr. Yang earned her undergrad degree in psychology from the University of Texas at Austin and completed her doctorates in clinical psychology at the University of Denver. She's an assistant professor in Manegar Department of Psychiatry and Behavioral Science at Baylor College of Medicine, and serves as a faculty leader and liaison to BCM for diversity, equity, and inclusion. As a staff psychologist at the Manegar Clinic, Dr. Yang has expertise in lesbian, gay, bisexual, transgender issues. In addition, she's worked with a young adult population, individuals with personality disorders, and on the cultural diversity issues. Her research interests include therapeutic assessment and diversity issues in the workplace. A member of the American Psychological Association, Dr. Yang has given several local and national presentations, including one on the importance of transgender training in hospitals at Arkansas State Hospital in Little Rock. And then after Dr. Yang, we'll have Dr. Paul Rowan of the University of Texas Health Science Center at the Houston School of Public Health, and the Culture of Health Advancing Together chat. Dr. Rowan is a clinical psychologist and associate professor with tenure at the University of Texas Health Science Center at the Houston School of Public Health. Dr. Rowan grew up in Spring Branch, yay, you're local, with its racial and clinical diversity. Dr. Rowan conducts research on the way that healthcare system does and might detect and address mental health needs, and on patient preferences for healthcare. He has been a longtime collaborator with CHAT on their school-based Girls Club for Success, social emotional learning projects, and many other projects. I know you've done amazing, amazing work with CHAT. Okay, how are we doing?
Yeah. Right, stop sharing. They said that they can see us.
Thank you.
Okay.
So
Perfect.
Just give me that. So with that, do you want to kind of just continue?
Yeah.
Let me continue to look and see the slides. You can see us.
Yep, here we go. Look at me. Okay, I will keep us going. So today I'm going to try to keep it to the foundation of the work that we do. We're going to be able to define gender-based violence and different kinds of abuse, understand the components of power and control, identify some of the challenges that immigrant survivors and folks from the Asian community are facing, and then learn best practices to help each other and other survivors. So the reality of the situation is that in all communities, 1 in 3 women and 1 in 7 men around the world will experience some form of IPV, which is intimate partner violence, in their lifetime. That is not a small number. There were, in Texas alone, 216 people murdered last year, which is 2022. They have not come up with the 2023 numbers, and that's an underreported number. This does not include murder-suicides. Many law enforcement agencies aren't able to capture those because of the nature of those crimes. Domestic violence can be called intimate partner violence. It can be called domestic abuse. It can be called family violence. Where we want to focus is the definition is there is a pattern of behavior in any relationship that is used to gain or maintain power and control over an intimate partner. So the key word here is power and control. So are the behaviors you're facing about behaviors that you're experiencing about gaining control over you? Anyone who's done any kind of domestic violence work will recognize the power and control wheel. This is called the Duluth model. And you'll see in the wheel, the center, as I mentioned, is power and control. And all the little spokes on the wheel are different kinds of behavior that somebody might experience. So there's threats in there, there's intimidation, there's emotional abuse, there's isolation, right? So much of this is not broken bones or bruises. It's not kind of what we picture when we hear the term domestic violence. The other thing I want to point out is a lot of these spokes may happen in an unhealthy relationship. Right? So we're not saying all relationships need to be rainbows and sunshine all the time. And will there be denying or blaming in a relationship? Yeah, and sometimes in your unhealthy points of your relationship, that can happen. But is there a pattern of that behavior? And is that pattern related to gaining power and control over another person? And then finally, are those behaviors cloaked in threats of physical or sexual violence? So that kind of dynamic will take something like, you know, oh my gosh, the fridge is open. It must have been you, you know, that kind of blaming on a one-time basis or every now and then, or someone's cranky or someone's having a bad day. And that might go back and forth with each other versus one partner consistently blaming another partner, cloaked with the veil of further violence. And the purpose of that behavior is to gain control over somebody and power over them. So that's really where our community can, and all communities can often struggle, because they say, oh, well, that's marriage. That's how husbands are. That's how wives are, right? We hear it all the time. But what is the intent? Is the intent to create fear? Is it to create power and control over somebody? Is there an explicit or implicit threat of physical or sexual violence? So there are many types of abuse. I know a lot of times we think of physical violence. So many of our clients who call us, especially a few years ago, would say, well, maybe I'm not eligible for services because he's never hit me before. And that is because of the stigma, right? We think that physical violence is the only kind of violence that is substantiated or counts. But actually, all these types of violence can have devastating health impacts, both mental health and physical health impacts. So there's physical violence. I don't want to minimize that, especially when we talk about things like gun violence, which is really becoming a big issue especially here in Texas, and strangulation. The fact of the matter is, if somebody puts their hands around your throat and causes you to lose consciousness or lose your breath, and that becomes non-fatal, your risk of actually dying at a later time due to that abuser increases by more than 7 times. So the act of choking somebody, of strangulating them, is an intense risk factor for homicide. There's emotional and psychological abuse, right? Gaslighting somebody, telling somebody that something is always their fault, or treating somebody very poorly and then saying, what are you talking about? I didn't do that, making them question their own reality. So when I think about emotional or psychological abuse, it's trying to control someone's emotions, trying to make them second guess their sense of self, how they feel about themselves. And I include verbal abuse here too. So really screaming at somebody, putting them down a lot. And I will say, if you see some of this in your community, amongst family, amongst friends, almost 100% of the time, what you are privy to, what's happening behind closed doors, is much worse. Financial abuse, 99% of domestic violence cases include some financial abuse. We live in America. I won't go on a, capitalist, anti-capitalist raid, but we need money to survive. And so one primary way to control somebody is to control their finances. So that may mean saying, oh, no, you can't work, you have to stay at home. It could mean you gotta work, but all this money is going into my account. It could mean here's your allowance. If you're in a relationship where you are not privy to what the budget is for your family and able to make decisions around how to spend that money, this is yet another red flag. And if that behavior continues, and if the intent of that behavior is to control you, that is where we're looking at abusive situations. Spiritual abuse, this is using religious text to validate the abuse, to say, and let me tell you, this can happen in any religion. It's cherry picking lines in religious text to say what I'm doing is God's will. And that's why our relationships with faith communities are so very important. Sexual abuse as well. This is inappropriate touching, groping, sexual contact, forcing somebody to have sex. Again, the reason why people don't often think, oh, my husband can rape me, the reason why people don't think like that's a thing is because it wasn't against the law until like the mid-70s. And so, but these are, again, ways that people can control others. Reproductive coercion is a big part of this, not allowing a woman to be on birth control, forcing her to have children. And that is because that puts her in a position where she further has to be trapped into this relationship. And then stalking, especially with young folks. We have seen stalking increase like never before with social media, with all of the ways we communicate online, especially in our community, right? We all love WhatsApp, we're on it, we're talking to people from all over the world. This is a really dangerous way that somebody can stalk a former partner or somebody who has said, hey, I don't want to be in this relationship anymore. This also includes manipulating pictures to humiliate people, to make them, putting someone's face on a naked body, or again, if somebody has texted an intimate picture to their partner when they were together, using that, spreading it widely, using dummy phone numbers, tracking someone's cell phone, tracking someone's car. These air tags these days, very, very clever ways to track and stalk people. And again, this happens in all communities, including ours. Let's see. I will. Yeah, if you could just, thank you. We might go old school.
If they move the computer here, would that be better for you?
No, I think it's fine. It was working a second ago. Probably talking too long on that side. There we go. Okay. Yep. So the number one question we always get is, why doesn't she just leave? And the reason is because, yeah, if I started dating somebody and then they, on day one, they started hurting me, harming me, talking down to me, controlling what I wear, who I see, sure, I would just leave, right? But that isn't the way this goes. So the cycle of abuse is that you're first in this honeymoon phase there on the left, where there are promises and gifts and love, and then tension starts building, and it's criticism, and it's blaming, and it's this percolating anger, and that can explode to where you see outbursts, threats of attacks, physical, verbal, emotional, sexual abuse. And you would think, what a great time to leave a relationship. But then immediately after that, you're back in the honeymoon phase. They are apologizing. They're saying it's never going to happen again. And what is cloaked over that is society also telling us, you stay in a marriage. A marriage is for life. A broken relationship is a failure, right? These are the messages that we're getting. So when you get that honeymoon phase, in that honeymoon phase, you think, you know what? I will be a forgiving person. Forgiveness is a big part of our cultural norms and our values. But then that tension starts to build again. So what we tell people is that in this explosion phase is actually a really dangerous time to leave. If somebody physically assaults you and then you flee, that's actually when a woman leaves, her risk for homicide increases multiple fold. And so that may not be the time to leave. So when we tell people, oh my gosh, this happened, why doesn't that person just leave? We're asking the wrong questions here. So instead, what we say is that if you're in these honeymoon or tension building phases, this is a safer time to start planning your escape, planning it slowly. This isn't a one-time thing. We have seen time and time again that people lose their lives when they try to leave. As you hear about these DV homicides in the news, pay attention. You'll almost always see that it was as the person was leaving or in the months immediately after. So a little bit about Daya. Our story is that there was a group of South Asian women who saw this as a problem in the community, and they wanted to empower South Asian survivors to provide them with culturally specific and trauma-informed services. Trauma-informed meaning not asking what's wrong with you, but rather what happened to you. And our team consists of our staff, our board, and our volunteers. Some barriers that exist in the Asian community are language, right? If you can't tell your story in your own language, it gets incredibly difficult. Finances, we talked about financial abuse, but then imagine being an immigrant who isn't able to work, or who maybe worked in the home country and now comes over here, doesn't understand credit scores. We see so much fraud. We see partners who say, sign this piece of paper. And because of the threat of violence, they'll sign the piece of paper and then they end up in hundreds of thousands of dollars of debt. Isolation, easier to do when your family's overseas. Lack of trust in mainstream systems. This is an important one because it hits really all communities of color, and particularly the Black community in Houston, we cannot ignore police violence, and we cannot ignore the pressure that women of color feel to not put their husbands in the prison system. And this is a major reason why people are not calling the police. They're not going to the courts. They don't want to involve others. In the Asian community, it's because it's such a shame on the family. You don't even, you don't want an ambulance or a police car coming to your house. So this is a big barrier. Anyone who calls DIA does not have to, and I think this is true of all agencies, it doesn't require police intervention. There's other things that we can do. Immigration abuse is bringing someone over on a fiance visa and then not turning that visa into a spousal visa. And then that person is left undocumented. So then if they do call the police, and now we're looking at laws like SB4 going into effect in March, if they do call the police, the fear is, go ahead and call the police. I will tell them that you are undocumented and you will be deported. And that's a very real threat. And if your child was born in the US, you are deported without that child. That child stays with the abusive partner. And so this is a very impossible life or death decision. In-law abuse in our families, one of the best things about our culture is how close-knit we are with extended family. But if that is an abusive system, that means it is 24/7. And when you have generations living together, that becomes a problem. And then transnational abandonment is flying one person overseas to perhaps visit the family and then leaving them there, canceling their ticket back, coming back home, filing for divorce. The wife can't afford to come back. She can't respond to that divorce. And what that means is that it's a default judgment and that the abusive spouse gets everything that they asked for. And we see this frequently. So again, our services include safety planning, licensed therapy, navigating these systems. These systems are new to everyone, housing support, legal advocacy. We're working with survivors on economic empowerment. It's really important that we do that even and especially with undocumented folks. Outreach and prevention, and then of course, advocacy, pushing for bills that make barriers for survivors less instead of more. I want to point out again, for immigrants, 75% of abused and undocumented women revealed that their spouse had never filed immigration paperwork for them. So they are left undocumented. Again, this is why the Asian American community needs specialized services in this area. So again, just responsibilities of the community. We want you all to stay safe. However, we want you to be informed, we want you to speak out, and then most importantly, create a safe space that's confidential and caring for survivors to talk to you. We keep it simple: recognize, respond, refer. And what that means is recognizing the signs of abuse, not just physical, but isolation as well. Responding by believing them. Listen, the whole system is going to question them. Can you be the person that just believes them? I love that part of my job because it's very, very easy to just not, you don't have to be the judge and jury here. Showing empathy and compassion, most importantly, maintaining confidentiality. They know their situation the best. If you go and try to intervene, say, oh, let me talk to him, that can put them at risk for homicide. And this one's a little counterintuitive, but don't offer advice. Instead, provide options. Here are the places that you can call. The last thing you want to do is be another controlling person in someone's life. And then as you're helping folks, think about if you're keeping yourself safe. Are you offering too much? Are you putting yourself at risk? Are you taking control? That's not what you want to do. Are you in over your head? I always say if it's keeping you up at night, you've probably exceeded a boundary. Are you too emotionally invested? And then are you an expert? I am always like, I'm not a lawyer. I don't play one on TV, right? Like, do not give legal advice, but who can you connect to that can offer that advice? And then refer. I would say all of our, since COVID, domestic violence has been insanely on the rise. And because of that, every domestic violence agency is near or at capacity. Offer multiple phone numbers. When you're offering the Houston Women's, Houston Area Women's Center as a shelter, can you offer Fort Bend Women's Center too? Can you offer the Shifa Center as well? Right here, when you're offering DIA, can you offer ADA as well, right? When you are referring people to services, give them more than one phone number. You can also offer to support in the background. You can help them document their abuse. That can be very important in a court case. And also if they're minimizing their abuse, it can be important for later you to say, look at all the times that we've talked and I've written down the things that happened is really powerful. Working out code words with them. So if I'm in an abusive relationship and I talk to you and I say, if I call you and say, hey, the dog is stuck under the chair, like whatever the phrase is, that's a signal for you to call the police. So you can work that out with close friends and family. And then money, again, when it comes to being able to flee, go to a hotel for a couple of nights, if our shelters are full, just cash can be really, really helpful for people. And then always check in. Just because you referred, nothing may have happened. And so you want to always check in and make sure someone's okay. Let's skip that. This is a wonderful QR code. Everything I talked about, this was compiled in coordination with ABDA, which is Aid to Victims of Domestic Abuse, DIA, and the Harris County Domestic Violence Coordinating Council. I'm going to leave this up here. This is a toolkit for community members. So it talks about the recognize, respond, refer. It lists all the numbers of all the DV agencies in Houston, all the shelters, and all the local police departments. It also gives you some questions to think about, ways, sentences, because it can be overwhelming if someone says, hey, I'm in an abusive relationship. So it gives you like sentences that you can say, I believe you. I'm sorry this is happening to you. They may seem really simple, but I promise you, it may be the first time someone's hearing that sentence. So I'm going to leave this up here. And I think that was my last slide. Yes. And so everyone can be sure to grab it. This can live on your phone. You can share it with others. And this has things that are culturally specific, but it is very helpful for the whole Houston community. It is a Houston-based toolkit.
Thank you so
Thank
very
you.
much.
Thank you.
Thank you. It's instrumental for us to kind of continue the conversation, moving over to women and also the prenatal aspect. So with that, I'm going to go ahead and turn it over to Dr. Yang.
Okay. And before you do that, I just learned, or I didn't just learn, but I was just reminded that the number one way, the number one cause of death for pregnant women is homicide.
Well, they just can't
Win. More than any other medical reason, it's homicide.
Do I just go straight to? Oh, okay. All right.
And again, for those in the virtual world audience, please be sure to type in your questions. And you can have a comment you want to share with us. We'll definitely read it out shortly during our Q&A. And we want everyone to kind of hear your thoughts out there in the virtual land and be sure to have the conversation here, bring the conversation into the room with the rest of the audience.
And I think virtually they're able to scan this too from their screens. So, but I can email it to you. If that's, yeah.
Yes. So we'll definitely have post the summit, have everything in the preceding handouts as well as the slides. This will definitely be in one of the slide presentation that you can also scan. In the meantime, if it's still up, if you want to use your cell phone, scan it, you'll be able to access the toolkit right away. Just pulling it up. And I want to thank everybody for joining us today for this conversation. It's actually much needed, and especially post-pandemic, we have seen so much of the different situations, scenarios, that it's very timely that we bring this conversation back into community leaders and back to those who are providing services and care so that we can actually work with decision makers and policy makers to create some additional leads to resources or make sure that we empower some of the providers, medical providers, as well as caseworkers to be able to better link the access to help.
Just call Justin because it's not airing again.
It's not
It's not airing. I mean, it's not.
Do you need to stop sharing first? maybe it's not sharing that first. That's what I think. We have to be moving on to that. Unfortunately, I think you'll keep that on the internal, so it's something to exchange, so you have to probably go back to the extend line one side. In the browser and then log back into that.
There we go. Great. Okay. So I should try the signature. Oh, okay. All right, great. I guess we'll get started. So postpartum or perinatal mental health is something that I'm really interested in. I think I did just a podcast at Menninger about this because I do think it affects so many women and it's really quite underreported. So I want to just briefly go over definitions. I know we don't have a ton of time today, so I may not finish all my slides, but be happy to, again, email them out and talk to anybody who's interested. So when we're talking about perinatal, what we're really talking about is the time frame between conception through the first year after giving birth. So it encompasses all of that, right? And today I'm going to touch on postpartum depression, anxiety, psychosis a little bit, but postpartum PTSD, and specifically how those may affect sort of the API population uniquely and differently. Now some of the terminology, people are using the term PMADS, which is perinatal mood and anxiety disorders, instead of going through like postpartum depression, postpartum anxiety, right? So if you hear me use that, that's kind of what I'm referring to. Okay, so why are we discussing perinatal mental health? While childbirth is biological, practices surrounding pregnancy, childbirth, and postpartum are social constructs. So it varies from different cultures. Again, why we're kind of having this topic in this summit. Medical professions need to factor in the influence of traditional and cultural values and practices on maternal healthcare utilization, which I'll get into when we're talking about the API population in a second. So why is this topic important? So 1 out of 5 to 7 women experience perinatal, again, during pregnancy or postpartum depression. Now, there's quite a bit of research to show that that's probably pretty underreported, right? That it's likely higher than 1 out of 5. And again, if you go from research study to research study, you'll notice the sort of the percentages really differ, which really shows you we don't have a good grasp or understanding of how many women actually suffer from, say, postpartum depression. During the perinatal period, there's an increased risk also for mood and anxiety disorders, right? So we're talking about depression, bipolar disorder, generalized anxiety disorder, OCD, so obsessive compulsive disorder, and PTSD. What you'll notice is one major risk factor that we see for women that develop sort of PMADS postpartum is if they have had a mental illness previously, especially if it's a diagnosed mental illness and it has not been treated or was sort of treated unsuccessfully. Treated unsuccessfully, they are at a higher risk of developing sort of PMADS postpartum. We see this quite a bit also with a woman who has had a history of, say, bipolar disorder, bipolar 1 disorder. She might have had a manic episode like 5 years ago and was relatively successfully treated. But if that's not watched by a psychiatrist or an OB-GYN who's quite aware of her mental health history, she could develop mania pretty quickly postpartum, and people are like, whoa, what's going on, right? So if this is just something to kind of hold in mind, if there is a woman who has had a history of mental illness and it's been documented, she's been diagnosed, she was potentially on medications, be very aware of that as she is going to the postpartum period. Was that? Okay. When we're talking about OCD, obsessive compulsive disorder, I won't get into this too much, OCD and postpartum psychosis. Those are more rare, but those are conditions that women can develop postpartum. So with a woman who has postpartum OCD, what you'll notice is that she'll have obsessive, ruminative, intrusive thoughts around maybe hurting her baby, somebody else hurting her baby, sexual unwanted thoughts about her baby. And to be very clear, when we're talking about, again, OCD, these are unwanted thoughts. For the woman, this is very, very distressing when she doesn't want to have these thoughts, right? But they are very intrusive. We have women coming into our clinic saying like, just in tears talking about, I'm just having this intrusive image of throwing my baby out the window. The woman, she does not want to throw her baby out the window. She would not actually act on it, right? But it's the idea of how distressing it is, because you'll hear her say, why would I think that? I'm such a horrible mother. I can't believe that I would think thoughts like this, right? So again, she can get treatment for that. It's not very common, but we do see it. We see a more common PTSD, which I'll get into. Postpartum psychosis, I just kind of want to kind of let y'all know, this is pretty rare. It's 0.1% to 0.2% of births. But the concerning thing with postpartum psychosis is that it's very much a sudden onset. So she'll be like, okay. And then all of a sudden have a delusion that her baby, is a devil, right? Or, her husband is trying to poison her in the hospital, right? And so that is something to watch out for, because what you'll again notice is that she'll be doing okay, not exhibiting signs of other mental health distress. And then all of a sudden, kind of like overnight, she'll develop postpartum psychosis. So treatment needs to be very timely for postpartum psychosis, okay? Sorry, is it? Okay. So I'll just briefly go over this. One study showed that immigrant women specifically are almost twice as likely to suffer from postpartum depression than non-immigrant women. And in 2018, so this is a little bit dated, we need newer data for this, reported that the prevalence of self-reported postpartum depression to be highest in American Indian, Alaskan Native women, followed by Asian American Pacific Islander women, and then Black women. Again, that probably has shifted a bit given sort of COVID and the pandemic, but that's sort of the data that we have at the moment.
Okay, can I ask you a question?
Yes.
There are pregnant women who are inmates in the prison hospital in Galveston. After the baby is born, the baby is taken away from her.
Mm-hmm.
I don't think that's healthy for the mother.
No, it's not healthy.
Normally, I can't even say this.
We'll hold that conversation.
Okay.
Sorry.
Yeah. I would love to have that
Thank you.
conversation. Absolutely. So why are PMADs undetected and underreported in happy women?
Yeah, sorry.
No, you're okay.
Wait, no.
Okay. So we've already kind of talked about this in the summit, so I won't go into it too much today. And I think there's actually going to be maybe a talk about this tomorrow in the summit. So I won't go into again too much. The need to suffer in silence, though, I will say is something that we do see a lot with women. This idea that like, I'm a mother now, all my life is surrounding this baby. I have an elevated status now as a mother. And this idea that suffering in silence is sort of like noble, right? Like I shouldn't complain. I have a healthy baby, or I have healthy twins. Like, why do I need to complain? Not only that, I have a healthy baby boy. I've always wanted a boy. The whole family wanted me to have a boy. So they don't feel like they have sort of the right to be suffering from, say, something like PMS. So I won't again get into this too much. The last one about belief that motherhood should be wonderful is also something that we see, not necessarily unique to the Abby population. We kind of see this all around, but this idea that like, I've always wanted to be a mom. We had this wonderful baby shower, and now I have this beautiful baby who's healthy, and my friend, his baby is in the NICU, but I have this healthy baby. They, again, feel that like they should be enjoying motherhood, that all the things that come with a colicky child, they should still be enjoying that, right? So there's not a ton of validation that they can hear that actually like being a mom is very, very, very tough, right? Okay. Cultural traditions and beliefs. We know that pregnancy and birth complications increase the likelihood of a woman experiencing PMADs. I haven't gone into too much like the factors prior to conception that will increase PMADs, but this is something of note. So when we're talking about pregnancy and birth complications, we're also describing the fact that a lot of times a woman is in a hospital giving birth to a baby in an environment in which she is not familiar with the language. So when we're talking about, again, an Afghan population, immigrant population, refugee populations, right? So when there are interventions that are taking place in the hospital because it's necessary, she may not understand what is happening. So when there's vacuums that needs to be used, when there's forceps that need to be used, she may have no idea why does she need an emergency C-section, right? This was not her intention, like what her intention of giving birth to a baby is. And I'll get into that in a little bit if I have time, but that is something that you see quite a bit, is how sort of the language barrier and different cultural expectations can really increase the likelihood of postpartum anxiety. And we also see as postpartum PTSD. Just a little bit about my own experience. I have 2 boys. And I am fluent in English, but I remember going to the hospital the first time and I was in labor and then they had given me Pitocin, which now looking back would not have done that. And my baby's heart rate dropped precipitously. So like 7 people, I kid you not, rushed into the room. I had no idea what was happening. Somebody was telling me what was happening in English, but very quickly. Luckily, I understood. So they were like flipping me around all types of ways. But there were men and women in the room helping me, right? So imagine a woman here who there is a lot of emphasis on privacy, on emphasis on, men not seeing the different parts of you that are not appropriate. And then having that happen and somebody telling you what's happening, but you have no idea what's happening because it's in English, and then feeling violated in the process of this, all the while knowing that your baby's heart rate is dropping and what's going on, right? So imagine what that would be like, again, for a woman who may not be understanding what's going on, and then also her family potentially in the hospital who do not understand what's going on, right? So just again, using my own experience to kind of illustrate thinking about what it would be like for somebody else. So cultural traditions and beliefs. We need to consider that, again, API women are coming from different cultural backgrounds. So this is really kind of important when we're talking about the protective factors against PMADs, right? Are there ways that during the pregnancy period and postpartum period, we can help a woman and her family be able to practice some of the cultural traditions that are important to them? This can get a bit tricky, right? Because if any of you have ever been, if you've ever given birth in a hospital here, or know a family member who's given birth in a hospital here, they can be pretty strict about like what you need to do, what can you take, what can you give your baby, right? In some traditions, the baby's first taste of like food is not necessarily like breast milk, right? It might be actually honey, for example. Here in the US, like we have the biggest no-no. I felt like in our labor and delivery class, our first thing was you do not give a baby honey until they're a year older, right? So I think that's something that we need to kind of hold in mind is like, can that be distressing for mom and also the family, right? And could that increase the likelihood that she would experience a lot of anxiety? In some cultures, you're not the person, the mom is not necessarily the person who's naming the baby. You wait until elders in the family name the baby. At the hospital, I remember they were like giving me the birth certificate. They're like, give us the name now. And I was like, and we hadn't come up with the middle name yet. I literally made it up on the spot for my second born, which sorry for my second born child, but that's something to hold in mind, right? Again, that can feel very distressing for a woman and her family and feel counter sort of to her culture, right? So again, something to hold in mind. Family dynamics. So something of note around family dynamics. They can be very protective for the woman. There's been quite a bit of qualitative research that I was like looking over, and family support, as we know, in collectivist societies, is really, really important. And women have indicated that female family members, like if they have the support of their female family members, they're in the hospital or, in their home, that felt really comforting to them. At the same time, on the flip side of that, there's research that shows that because of how tight-knit families are, this can actually be kind of detrimental to the woman's mental health, right, in some ways. There were, some studies that show that if a woman who didn't have a lot of family support, her family was back home in India or whatnot, but she's coming from, again, a society where men kind of expected the woman to do the work in the home, he's a breadwinner, and so she has this newborn, and she has to, wash all his laundry and, clean out the dishes and cook because she doesn't have family support here, right? Particularly female family support. That is going to increase the likelihood of PMADs, right? So when we're thinking about intervention, you really need to think about kind of capitalize upon like what supports does she have, right? However, another thing is when you look at some of the research, what you also see is that people who are more assimilated at times will consider like sharing the burden of labor of like washing the clothes or doing the laundry, like the husband or the partner would actually partake in that. And then that's been seen as supportive. The woman experiences that as supportive and helpful. Something that Rasha, you talked about was conflict with in-laws. Yeah, if you're living with your in-laws and you're like, my in-laws are the best thing since sliced bread and they're super helpful, that is very protective, right? That is very protective for specifically postpartum depression that we see quite a bit. On the flip side, if your in-laws are emotionally abusive, if they're pissed off at you that you had a girl instead of a boy, you know, if they feel that, you know, they're expecting you to treat the baby in a way that doesn't feel comfortable for you, right? And yet you don't feel like you have the voice to say like, I'm not comfortable doing that, right? And even if that's not in-laws, but your own parents, for example. I just remember postpartum, my mom was like appalled. We sleep trained both our kids, and my mom, she like lost her mind. She was like, what is this sleep training thing? We don't do this in China. You just sleep with the baby until like you don't sleep with them anymore. And I was like, we're not doing that. I have work. I can't do that, right? But that's something to, again, just kind of hold in mind is that family support could be very protective, and at times it can actually be quite distressing too. And also, to Rachel's point, intimate partner violence, right? Was that happening? And also what we see in the research too is that postpartum untreated PMADs can increase the likelihood of intimate partner violence, right? So like if you think about it, it's kind of like if you're already experiencing violence in the home, you develop postpartum depression because you're experiencing violence in the home, and then you are actually abused more as a result of it, right? So just keeping that in mind. And also lastly, how is mental health treated in the family system? This is, I won't go over this too much, but thinking about particularly for immigrant women, and I won't go into too much, but because Dr. Rowan might speak to this, but that's something to also think about, which is what are the additional stressors, including oftentimes, again, fleeing a country if you're a refugee, and you're already suffering from postpartum depression, or not, sorry, PTSD, and then you get pregnant. Back to the medical interventions piece. So medical interventions are not necessarily considered the norm in other countries. So this is something to kind of think about. I feel like I really grew up with this idea, like if you are going to go have a baby, you go to the hospital to have a baby. That is not necessarily the case in a lot of other countries. A lot of times women will say like, I feel like it's quite shameful because I feel like I have to go for an illness. Like I'm going to a hospital to have this really, it feels like it should be a very natural celebratory event, right? So again, going to the hospital can already feel shameful. And then again, if they're having medical interventions that they did not plan for or that they do not know about, that can also be quite traumatizing, right? So when we're talking about postpartum PTSD. Again, disrespected and violated, especially if modesty and privacy is important for a woman in their culture. You'll notice in what kind of the research shows is a lot of times API women will really pull for a female OB-GYN, right? They feel very uncomfortable with a man in that regard. I think I'm almost at time. Okay. So I'm going to skip this a bit. So this is just want to emphasize this. The gold standard is the EPDS. This is a free screening scale. It's only 10 questions. You can print out online in multiple languages. They're trying to find a better one. The reason being is that it's very much tailored to the emotional experience of postpartum women. So like, I feel like crying all the time. I feel sad. And that does not necessarily translate for API populations who may not actually be in touch with their emotional experience, but might be saying like, I have a lot of pain in my body. Like I have so much fatigue, and is that normal, right? So we really need to have, again, a culturally informed scale. And I think I'm probably at time. Okay, probably a little bit more. Okay, but this is just something that, again, it is a very simple scale. It's only 10 questions. You can all print it out online. The importance about postpartum screening is because postpartum screening is still quite low for women across the country and across the board. And when it is done, it's done in a very impersonal way because oftentimes practitioners don't know what to do with it. Like if you say you are crying all the time, like what do I do? What do I say? How do I comfort? How do I intervene, right? But what we really need to think about is individuals who encounter women during the perinatal period are really the people who can actually do this type of screening, right? So lactation consultants, That would actually is a huge one. Midwives, nurses, your religious and faith leaders. We kind of talked about that today in the summit and the importance. Your pediatricians, your primary physicians. I would emphasize like that needs to be a priority for training for these individuals to actually be able to talk about like what is PMADS, right? And to feel comfortable sort of screaming women. And then kind of to your point of Rasha, of like referring them to the right people, right? They're not going to be doing the therapy, they're not prescribing the meds, but they can say like, hey, these are some people that we have that are vetted that you can reach out to. Okay, all right, I'm going to stop there. We're going to take up all the time. So thank y'all. There are some slides left, but I think those could be.
Thank you, everyone. Again, if you have any questions or concerns for Dr. Gang or for Ratna, please make sure that you type in your questions or other comments into the chat, and we'll read it out shortly. With that, I'm going to go ahead and pass the mic over to Dr. Paul Rowan as soon as we get the PowerPoint pulled.
While we're waiting on the slides, I see he has them there, they'll come up. I do want to say that the slides have been some of my team is here. Fatima and Marin are some chat folks. They're a couple of our community health workers, and we're going to be talking about what community health workers are doing in immigrant and refugee communities. And going as the third speaker here, so much context has been presented, it'll make it easier for me to hit the unique things about this. Okay. Here we are, chat is culture of health advancing together. Let me see if the slide advance works.
Oh.
Did I go the wrong direction?
Oh, yes, that's.
Figure out which button to press. Okay. Okay. All right. So, and so I've put these slides together just recently out of some stuff that's already been put together and a couple of research projects we've done. We've done a couple of research projects gathering data that have piggybacked on our community health education and community based healthcare delivery that we've been doing. I say we, it's not me. I'm not a community health worker. I'm not out in the community knocking on doors in apartment complexes and giving people COVID shots and so on. But our community health workers are doing that. And they've been doing that for a good while now. Chat mission, foster the health and well-being of immigrant and refugees through education, arts, advocacy, and access to care. Vision is to build a healthy community that is self-sufficient and meets the everyday challenges of living in a diverse society. So this kind of gets to that acculturation aspect that some people have talked about. And you know, there's a lot of stuff where we pay attention to that a lot of things that should naturally be happening for families, young people, etc. The immigrant and refugee experience really just puts a big twist on everything. And so we have to look out for each other and figure out how to address these things. Established in 2015, we do a range of services, like we've mentioned, social emotional learning programs in schools, women's sewing circle, door-to-door health survey outreach. Gulfton Story Trail is, and we chat particularly is focused in the southwest part of town, particularly in Gulfton. And as we've mentioned, Houston's notably diverse, and a lot of immigrants and refugees are heavily in the Gulfton area. And there's a set of murals there that Chat has collaborated with other organizations to get painted there. It has been 13. There's a couple more. And so look for the Gulfton Story Trail if you're not familiar with it. It's putting murals on the sides of schools, business buildings, the sidewalls of apartment complexes with different themes about success and cultural integration and so on. And the hope is, and the belief is that when people see these images, they see faces that look like them. When they see these aspirational themes or these things recognized in the migrant experience, et cetera, it makes people feel like the community that they're in is theirs as well as everybody else's. And so we hope that there's evidence that says families will reach out. The more that families are acculturated or feel like the culture is theirs, the more they'll reach out for social services, the more they'll reach out for health care they ought to be getting. So we know that from research stuff, and those are some of the things that that we are interested in. So I'm going to talk a little bit about challenges faced by Houston's Afghanistan refugee families through the COVID crisis. We work with a lot of different immigrant and refugee populations, but I'm going to talk about some stuff specific with the influx of Afghanistan refugees that we've had in the last couple of years following the end of the Afghanistan war. Okay, from these two studies, like I said, these have been carried out in the context of a bigger project to do health education promotion, including COVID interventions. So, and there's chat. There we are with our sunflower yellow on out in the community. Okay, we use, there's a lot of these models. We use the determinants of migrant vulnerability model. You've heard all this stuff today. There are individual factors, household and family factors, community factors, and then more broad structural factors. And so we keep kind of this theoretical stuff in mind as we go do pragmatic stuff on the ground. So, okay, we did a qualitative study asking basically, what are you doing to keep yourself and your family safe from COVID, and where do you get your information? And we ran a focus group, a group with some women from Afghanistan and men from Afghanistan. So I sat in on the men's group, and we had a gentleman who was working with chat at the time, who knew the languages to lead it. The entire conversation in there, I didn't know what anybody was saying, but I can tell when a good conversation was going on, and I was thinking, great, once we get this translated and transcribed into English, we're gonna have good information. But I had no idea what people were saying. But you could tell the young men in there really appreciated an opportunity to talk about some of their challenges in there. And then likewise, that they, if you're doing a qualitative group interview with a bunch of Afghanistan women, you want to try not to have men in there. And and so a lot of the stuff we're talking about is a kind of family, social context that people have talked about. And we see these communities as hard to reach by public health efforts. As people have said, immigrant and refugee communities are getting their information through different avenues than the general population, than the dominant culture. I may be watching KPRC local news every night and talking with other people I know who have grown up in Houston, what roads are iced over, and I know people that live in different parts of town. Well, we're talking about different avenues that information is flowing down when we hit situations like that. Okay, so we did the two focus groups carried out in Pashto and Dari, transcribed and translated to analysis. I'm not going to go into the methodology, but I'll talk about the findings in general and then findings specific to COVID. So again, the idea is, what are you doing to keep yourself and your family safe from COVID? And again, one thing I want to emphasize is we've recognized that women are really in charge of the homemaker role, seeing that the children are fine, seeing that the household is fine, food, cleanliness in the home, and all. So when COVID comes up, it really, that's the woman's burden. That's part of her role there, while the men are out working or looking for work. So it's good to interview them. So some of the findings. People reported an emotional impact from COVID, lack of typical coping resources, lack of social interaction was a very difficult thing. People not being able to go to their mosque, etc., where they normally could, commiserate or look or get some support from people. Online social networks kind of serve that purpose. Okay, women were concerned with children's welfare in school and their husbands finding work, while men were concerned with finding work to provide for their family. So that kind of that complementary gender role situation there. Social isolation made a lot of this very difficult. So I want to go to the next slide. Are we in there yet? I can't remember if I have another slide of general findings or the next one is the COVID specific. Okay, women worry that they might be treated in the women's interview. They said they might be treated badly if out in public they started exhibiting signs of COVID. Immigrants and refugees may be sensitive to am I gonna stand out? Am I gonna get singled out? Am I gonna get in trouble for something? And then here with COVID on top of that, if you start coughing, people are gonna be looking at you. Okay, so constant stream of information was distressing. The costs of it, the financial costs of addressing COVID were distressing. It's a new budgetary expense for whatever cleaning products and masks. And then this, the budget stress is captured by this one caption, quote, regardless of if COVID kills me or not, I must feed my children. So they have to make those choices there.
The shorts? No.
Yeah, that's fine. The slide flippers. Okay, so, okay, so we learned some about COVID, and we learned what's really important is people were getting their information through Facebook. And they also were largely getting their information through from their children's school. So it's important for us to share that information with other people in the community to say, hey, you can encourage things through people's language-based and culture-based Facebook groups. And then school is a good avenue. And so then we did, as our community health workers were going door to door, this is touching a little bit more on the challenges in the home regarding relationships and all. So along with talking about COVID and talking about health promotion, the community health workers were hearing a lot of stories about mental health, about suicidality, great stress and all. So we said, let's kind of do a general assessment of the degree of mental health burden in this community and ask a few more questions that get some at the family context. Okay, so we identified a survey for depression and one for anxiety. So that kind of gets these main mental health categories that are the most prevalent. The depression one is this PHQ-9 that Dr. Yang just pointed out. And the anxiety one is a common one. And we got those. So these have been translated in many languages. So I go to look for them translated into Pashto and Dari and Farsi, and I can't find them. So that's the type of stuff I do with chat is the scholarly stuff, like find, translated versions. Well, I just could not find these. So we've done a lot of translation on our own. So we did our own translation of these, and it's usually verbal administration. People may be literate in one of these languages, but we like to read the questions to them if we can, which is a better way to give a questionnaire validly versus wondering how well somebody understands the language when they're reading it, whether in English or other languages. And then we asked domestic questions about household size and who's working full-time and so on. So here's some of the, so we recruited, these results are from 89 women from Afghanistan that we had data for thus far. We've actually gathered more of these surveys, but we don't have those data together yet. But here's our findings from this first 89. On the depression measure, 12.8, we're at an elevated level. And so just a little bit ago, Dr. Yang was talking about a depression screener. This is a questionnaire that if you hit a tipping point, it says, hey, somebody should talk to this person to diagnose whether they actually have this disorder or a related disorder. The screener doesn't diagnose people itself. It's just kind of like, it's like a check engine light to warn you, maybe you should go check further. But it is used in population-based and community-based healthcare to give you a gauge of what's the portion of people with elevated symptom levels of concern that ought to go on to further evaluation. So on the depression scale, 12.8%. On the anxiety measure, 16.3%. So I go and I look at normative data in a typical population, what would the rates be? And these rates are a good bit higher, 50% higher or so. So we have a community with higher rates going on. And then we talked about some domestic things. These are often, you guys know this, these are often families living in apartments, and they often have multiple people in that home, and which makes it stressful. And that's part of the migrant vulnerability model. When we get an infectious disease, is migrants are often living in crowded housing and with many people in an apartment. And so when something like COVID comes around, everybody's got to be real careful. Infectious diseases, the flu or whatever, are going to spread through there pretty quickly. And so, so that's just a burden that's on these populations. 14% reported living in households with 2 to 4 household members, 54 with 5 or 8 members, and 32% in households with 9 or more members. So, you know, if that woman's caregiver role in the homemaker role is to make sure the food is, you know, she brings food home from the grocery. There's a lot of, out of these different cultures, there's a lot of practices about washing your produce that naturally helped out in this community. There's a lot of cultural practice about regularly cleaning your home, mopping the floor, cleaning the bathroom well, etc., that serves as a positive when COVID came around. Of course, you know, we were all afraid of COVID, so everybody doubles down. So, and if you want to keep a house, an apartment clean for 9 people in there, you're going to be busy. So, that's looking at some of that stress or burden there. In these homes, 84% of the husbands were employed and just 7% of the women report being employed. So that really shows you these gender roles in reaching that. So, and then like we said, you know, that could be a strength in some of these things if it's very clear, you know, who's in charge of the food, who's in charge of supervising the children, if they're going to be on online school and this, that, and the other, it, you know, it kind of delineates who's in charge. But then it's, you know, the challenge gets high when everybody's being homeschooled. So among these women, there's notably high rates of depression and anxiety symptoms. These women play a very strong homemaker role for their families. It's common for households to be sizable. And while larger households may allow sharing of home expenses, these may be stressful for women in the homemaker role. Is that my final slide? Overall conclusions. While Chad is very aware of our local immigrant and refugee communities and the healthcare needs of these communities, we make sure we're keeping an open ear to go discover and learn what's out there. And I think that's one of the great things about particularly what Chat can do with community health workers going door to door in these large apartment complexes where a lot of the refugee and immigrant community lives. And so, so even more so than people feeling welcome to come to Hope Clinic, even Cena, and some of the other healthcare providers. We found great portions of immigrant and refugee residents in Gulfton who are eligible but not current on COVID vaccination. So it was good that we had the capability to deliver vaccinations. Community recruited community health workers are excellent for in-reach to these communities. We explain this in simple terms by language and culture match, which other people have mentioned here. And again, so I want to, you know, I want to thank, people asked me to come in and substitute in. Aisha Siddiqui, the director of Chat, was not able to come because of a travel disruption from the weather, getting back to Houston. So, so we scrambled and put this together. I'm familiar with all of this. I've been involved with it, putting this together and thinking it through and helping develop it. But our community health workers like Fatima and Marin really do the outreach door-to-door work. They do a lot of the organizational and management work and strategy work in the Chat offices and so on. So that's the end of our part. And I think those 3 really complement really well. I'm glad that y'all covered so much, so I don't have to.
Thank you so very much, Dr. Burren. So with that, we actually have 10 minutes for Q&A, and I'd like to invite the audience to chime in and also kind of ask the panelists some of the thoughts and concerns that you may have been thinking about during the presentation. Do we have anything? Okay, anyone from the audience? I like to go ahead and start first because, you know, I know for diet, you must have seen a lot of cases where one of the slides that you presented, you know, why don't they get out?
Yeah.
Why don't they leave? And I've kind of, you know, wondered about that myself as well and wanted to help the people from the audience better understand and better coach. What can we do to better work with ladies or even men? Because I know there's cases where there's men as victims, to be able to kind of step out or move forward with that situation.
I think the number one thing I would recommend is patience and confidentiality. So it's such a dangerous time. It is the time that people are most at risk for homicide is when they leave, because if someone's trying to have this power and control over you and then you're leaving, they start to really panic. And I want to say that, you know, with gun access being what it is, and the gun culture being what it is in Texas and in the South, in America, it is incredibly dangerous. If there's a firearm in the home, a woman is 5 times more likely to die if she's a survivor of domestic violence than if there's not one. So the most important thing we can do is be patient, recognize that leaving isn't like, you know, me just leaving my house for the day, right? You have to be very careful about the timing, about who you tell, about what you take. And it's a really traumatic experience. You leave, we've learned that these are, in many cases, the homemakers, and you are leaving all that behind. And so the patience there is really, really important.
So with that, you know, I know, one of the things that you had mentioned is the abuser had promised, and the honeymoon phase about I will change, it will not happen again. Are there support, or are there things that healthcare providers or those who are social worker or caseworkers can do to better guide those who are seeking counseling or support to for the people who are abusers?
Yes, so there is, we have to understand, and this is me speaking from Daya's perspective. There are different organizations that do this a little bit differently. Research shows that domestic violence is different than conflict or anger management because the core is power and control. So there's special therapy that's called batterers intervention prevention programming that is specific for batterers. Many times those are people who have experienced trauma themselves. They've grown up in an abusive home. That's the norm they've seen in a relationship. So this kind of therapy helps really address all that. Aid to Victims of Domestic Abuse, AVDA, provides this training. I think it's like 38 weeks. I mean, it's substantial. Many of the times it's court appointed because it's rare that somebody will say, yeah, I am an abusive person. I mean, that takes a level of self-reflection that we're not seeing because at the root of the abusive behavior is entitlement. So if you're so entitled to think, I can treat people this way and I deserve this, it's rare that you're going to say, well, let me change it. It's working out pretty well for them, you know? So, but batterers intervention is the gold standard of therapy for those folks. When we're working with survivors, even when they say, oh, but he's changed and this and that, a lot of times we just pull out that picture of the cycle of abuse and we kind of say like where, like you can, and it's mind blowing. They can point to where they are, like even like in between two areas of where they are in the cycle. And then the other power and control wheel we will share so they can literally make a check mark on the behavior that they're experiencing,
So I also want to open it up to Dr. Yang and also Dr. Lauren to kind of share your perspective as well.
Yeah, so in a similar project, I'm not going to say who I worked on this with because I'm not here in that context, but I worked with some providers looking at the situation. And yeah, like you're saying, one thing is recognizing that you're stepping into a very dangerous situation that is where that's very volatile. And so if you just say get out of there or tell him this, that, or the other, you may be making a misstep and guiding somebody into trouble. So the one thing is for the provider to understand that they're ready. And this is a big deal in healthcare where you get providers in different OB-GYN in different areas to get educated into this model. And then if they want to cross the line and say, okay, we're going to get educated and we're going to start educating women when we detect them, you know, look for signs and have conversations. That's a challenge. Some of the stuff is that abusive controlling partners do not want their partner to go see into a medical visit alone.
That's right.
Because they don't know what's going on in there and they may suspect they may tell on me, or the provider may ask, is this going on? Especially if there's bruises or anything like that. So it may be hard to split somebody off. I think in OB-GYN, it's a little bit more natural than some other healthcare
It's our
settings.
favorite place to have some
Yeah.
intervention work is at the OB-GYN.
So the recognizing you're in a difficult situation, doing that education, and then the next step is you know, like you're saying, given the choices, do you want to start to get together the components of an escape plan, which is going to be a place to go, a little bit of clothes, some money, who's going to help you, but you have to understand, like if you're going to leave, you're not leaving for 2 days for things to blow over.
Correct.
You know, so you can't tell somebody they need to make that decision. They have to arrive at that decision, but
That's
you can
right.
help them recognize the reality.
And the patience too is that on average, it takes a woman 9 times to leave before she leaves for good. And that's because you need a roof over your head, you need food to eat. And at the end of the day, this is somebody that you loved who said they loved you. This is very confusing. Did you have a question?
No, I was wondering if you provide any protection for this woman.
Yes.
They
Absolutely. So we work with them while they're in an abusive home or as they're leaving, after they leave, years after they leave. We'll work with them on getting things like protective orders through the court, help them do things like the McKinney-Vento Act, which helps their children stay at the same school, even though they may have to move out. If they have to move out of their apartment lease, we help them break the lease because there's laws out there to protect women, but the access, nobody really knows about them. So we're there to advocate for them in all those systems. Absolutely.
Dr. Yang?
I was just thinking of, so at Menninger, we're an inpatient hospital, and the number of times that we see partners come in, and it's usually not, they're not coming in because they're like, I'm an abuser, right? But they're coming in saying like, I'm depressed or I have anxiety or, you know, I'm struggling at work, whatever number of issues. And so they'll come in and we see this all the time. At that point, once they're inpatient and they're admitted, and let's just say that they're suicidal. So that means they cannot discharge or if they wanted to discharge, we would involuntarily commit them because we are a voluntary hospital. Then their spouse files divorce.
Yeah.
And then they put it on sort of like our social workers to be like, can you tell him that I'm leaving, I'm gone, because he's flying in from a different state. But this really speaks to, I think there is obviously a level of privilege in all of this, but I think this really speaks to that she did not feel comfortable in the home to even consider this idea of separation. But once he's in a facility to where she's pretty confident that he like can't leave or he will be involuntarily committed, then she kind of sets her plans into motion.
It's a deeply brave act because it's safer to stay until it's not. And it's really dangerous to leave. But if you stay and your children are watching that, kids are 4 times more likely to become abusers or to become victims if they see it in their home. So what these clients are doing, people say, sometimes people pity survivors of domestic violence, and I understand empathy and sympathy, but it is a courageous move for not just them, but really for our whole community, because we're preparing our children to know they deserve more.
Okay, so we have 1 minute left, so I'd like to go ahead and allow the speakers to wrap up, and then any last minute thoughts to the virtual audience and audience today.
Can I add something that's important? Don't be a policeman. It's not your job.
Yes.
There had been a guy, he was cut up because protecting his employee from the abusive husband.
Yeah.
So don't do that.
Yeah, as you intervene, your safety is incredibly important, physical safety and your emotional safety too.
Definitely, that's actually really excellent. Yeah.
The toolkit will tell you how to intervene safely. Safety for bystanders is first and foremost.
And I would say one thought is downstairs when in the main talk from Dr. Shaw is if you're working with community groups and advocating for and for different immigrant and refugee communities and all, be aware and help make the folks that you're working with be aware that healthcare providers and social service providers, the generation of people that were uneducated and insensitive to this thing is, I don't know if there's anybody still around, but you know, the training that I got in the 90s is probably not as good as what the training that you've gotten, but you know, this is stuff that's in the social service and the healthcare delivery and the education world. So people should not be too particularly scared to look for help,
Yes.
ask for things, ask for a translator, bring up culturally sensitive things, like if they want their child's first food to eat to be honey, bring things up like this to discuss them and see what happens.
I love that.
Respect their culture.
Yes, sir.
Never hurts to ask, right? Yeah.
Okay, great, wonderful. Thank you so much for your participation today, and thank you all the presenters. Give them a round of applause. So with that, we do session 1, and we're gonna invite everyone to go down to the first floor where we're gonna have a great. Appreciate it. Oh, everyone, please take a moment to scan the QR code for today's session evaluation. Give us some feedback. This is something that is actually pertinent and important, or actually a great way to actually start a breakout session. It might have been me. Your feedback's very valuable.
It might have
Thank
been
you.